Equity Accreditation. Overcoming challenges. In case you don't know me, I'm Susan Moore. I'm the president and CEO of Healthcare Resources. I established in 1991. I became a surveyor in 1996. And we're really happy to have you here today. We have a lot of people who have registered for the event. We know that some that are affected by the hurricane and tropical storm have probably been affected and will be unable to join us because of either the internet or any power. And so we hope everyone stays safe. And we're glad that those who could make it did join us. And next slide. You know, MHR is a small consulting firm. We ask that you value the copyright and intellectual property. There we go. You can go to the next one since the slides are slower the more people that get on here. We are not representing NCQA. We are providing the best guidance that we have based on our years of experience and accreditation and our survey experience. We have more consultants who are surveyors than any other firm that I have been able to find. And not only that, but these surveyors also have previous NCQA accreditation responsibility in their health plans for 6 to 28 years prior to joining MHR. And a lot of them have health equity experience. And so, next slide, we want to be the ones who have been there, done that, feel your pain. And so we understand where you are in your journey because everyone has felt that. We're known for being detailed and holding plans to the highest level of the intent of the standard that NCQA has informed us as surveyors to do. And so we want to help you to learn to do it yourself. And this is very different than a lot of consulting organizations, but one that is our philosophy in teaching you to fish by providing the information to you and empowering you for what you need to do, where you need to go, and how you need to do that. And we're not prescriptive because of our experience. We know there's many ways to meet a standard. And so we explore with you the best ways to do that based on the way that your organization is formulated. Vision's important, and it's what drives us and helps us to lead you as we go along the way. Next slide. As this next one is just about our blogs and newsletters, and you will be getting. Yes.
Sorry to interrupt. This is Tanya. People are not, I just need to confirm if people are having sound issues. I see a number in chat that don't have sound, so I just want to make sure that that's not. It might be their issue. I'm trying to figure out if it's a big issue or if it's just a few people.
How would you like them to respond?
If they can just respond in the Q&A if they're having sound, I will try and find a phone number for them to call.
Okay, great. Thanks so much. So before we move into the presentation, there's a few logistics. As Tanya was just mentioning, she's our support for this, the webinar. If you have questions, please put them in the Q&A. And if you can see the slide number at the bottom of the screen, try to put that so that if we need to go back to that slide, we can do so. If not, if you just want to put the title of the slide, we'll try to find it that way when answering it. We will try to have enough time at the end of the presentation for your questions to be answered. We know there's lots of challenges. There's lots of questions for health equity. Some of them may be kind of detailed, and if you're one of our clients, the really detailed ones are best answered by your consultant. If you're not a client, we can take this offline. We're offering a free consultation at the end for non-clients who wish to avail themselves of that. we're only as good as the information given to us. So if we can't pull out the information and all of the different perspectives that can change the answer or affect the answer, it's very difficult to give you the best answer. And there's always a lot of details that need to be solicited. So Sonia will be answering your questions as best as possible, the information that she has. And I don't know if you saw the information in the news this week. A couple things came out from NCQA that addressed health equity. One of them was a STARS report and showed that there were only 5 organizations with 5-star ratings. And NCQA stated that one of the reasons is that they increased the scoring threshold for the race, ethnicity, diversity of membership, or RDM as it's known, measure, and increased the measure weight from 0.5 to 1. And said that as is their mission, it's really that ethnicity and race collection, data collection is really crucial for closing gaps in quality of care and promoting health equity. And by broader stratification and collect that data, ratings can drive continuous quality improvement across the healthcare industry, ensuring that patients receive the best possible care. And then secondly, on the 23rd, which was Monday, I believe, they announced a partnership with the Arizona Healthcare Cost Containment System, always get that wrong, AHCCCS, to support the state's Medicaid managed care organizations, accountable care organizations, the clinically integrated networks, and providers that are participating in the Targeted Investments Program. And they're doing that by coordinating activities that support health equity accreditation. A subset of those provider organizations, which are about 40 of them that comprise 120 medical, behavioral health integrated outpatient clinics, are pioneering NCQA's Health Equity Accreditation. And that allow the health centers to earn the accreditation seal that was originally for health plans. We know that health plans struggle with these standards, and I know that those health centers are really going to struggle if they've never been exposed to NCQA accreditation process. So it sounds like there will be some support there to help all of those provider organizations. So you can read, so I'm not going to read about the blogs and newsletters, but I'd like to introduce to you Sonia Fraser. Sonia has been with Managed Healthcare Resources for over 5 years after working at NCQA as a senior accreditation manager. And before that, she worked at a Medicaid organization, and she was distinguished as leading the team for the first ever multicultural healthcare distinction in the U.S. And that's been a passion of hers, and from that time until today and beyond. And she surveyed for NCQA for over 10 years, and she continues to do so and conducts many health equity surveys, along with being a team leader for MHR. She is our resident subject matter expert for health equity and presents on this topic nationally and also for MHR clients, and prepares our MHR clients for success. Health Equity Accreditation. I think you're going to enjoy the presentation she has in store for you today. So, Sonia.
Thank you, Susan. Go ahead and advance to the next slide. So I wanted to give a little background as the next slide's popping up. Many of you, as Susan mentioned, have heard about the Multicultural Healthcare Distinction, the predecessor to the Health Equity Standards. These were published back in 2010. And although many of us know that disparities in healthcare and equitable care have been a concern far longer than the buzzwords of health equity and SDOH became popular, and then thanks in part to COVID, the overwhelming disparities seen during the pandemic really shined the light and was likely the impetus for NCQA to transition the standards from the distinction to a full accreditation program. So why are we talking about that? Why am I mentioning that today? Well, when NCQA makes the transitions from programs of certification to accreditation, it's their way of conveying the importance of the subject. And with that has come stronger requirements. And so I know you've seen, if you've looked at the standards, the introduction of various other requirements, which we're going to talk a little bit about today, but also transitioning to the Health Equity Accreditation really gave it some teeth, as I like to say, and it comes with increased rigor around the requirements. Also, that transition included requiring an increase in threshold, moving from 70% threshold requirements to 80%, and also transitioning to that 2-year distinction, or from the 2-year distinction to a 3-year accreditation. Next slide. And previously, although the former MHC, as we called them, standards were touted as being applicable to MBHOs and population health management organizations and even wellness organizations, there were challenges as organizations were attempting to meet several data and communication requirements that simply may not have applied or were difficult to see how they applied to the organization. And with the introduction of the health equity standards, some of the terms even that NCQA uses in the standards were kind of redefined. So for example, expanding the scope of the term practitioners to not just apply to the provider networks that we see on the health plan side, but also those employed by the organization, say for example, by a hospital system or within a practice. So with the transition to health equity, this has really opened the door to allow other types of organization to obtain accreditation, which you'll see at the bottom of the slide. Next slide. So before we dive into some of the challenges that we've seen over the few years since the introduction and even the predecessor, I wanted to just give a really quick overview, which we'll see on the next slide here, of the key considerations and nuances specific to health equity. And these are really important, especially as organizations seek to obtain possibly their initial accreditation. And for those familiar with NCQA, there are some things that are not the same as they are on the plan accreditation side. So for example, when health plans are coming through for an interim submission, or when in other types of accreditations or certifications, when we see the term initial, we kind of think, well, we've got some time to put those things into play. And that's not the case with health equity. You will see that most of the requirements, especially for documented processes and policies and procedures, require the organization to have had these documents in place at least 6 months. So that takes time, right? And this applies to analyses as well. Similarly, on the accreditation side or even in other standards, analyses may not apply or might have a shortened or reduced time frame. Well, there are those requirements, health equity, and organizations are required to have analyses at least once during the prior year. So again, that takes time, not just to nail down the processes, but nail down the data and have a process in place to collect it and analyze it. And obviously, there's a lot of detail in the explanation, which we're going to talk a little bit about today. So hopefully, if you had an opportunity to look at the standards, you've probably seen that element looks short, but then when you get to the bottom, there's a great deal of explanation and things that we have to consider consultants as well as surveyors. Next slide. So let's dive into the challenges that we've encountered and also some possible solutions. You probably just heard me talk about time. So one of the first things that we've seen as a challenge as we've worked with a number of organizations, and as I've worked with organizations both capacity as a consultant and as a surveyor, I've encountered two ends of the spectrum essentially. Organizations that think they've been this already and can complete it in no time, and those that have taken the time to digest the standards and really assess their compliance with them. So in previous, we recommend that you consider a minimum of 12 to 18 months lead time in preparing or in obtaining the accreditation. Now, most might have a requirement, or some might have a requirement from the state, or regulatory requirements, or even internal requirements that want you to have the accreditation within the calendar year. But think about what I just said with the documented process, the need to have those in place at least 6 months. If an organization decision to submit within 6 to 9 months, and let's say you submit your application, you have about 3 months to prepare. That's not allowing a great deal of time, and it really sets yourself up to rush and potentially not succeed. And one of the things, not to jump ahead, but one of the things that we want to, or that we do with our clients, is to set you up for success. And being able to maintain that accreditation is important, and maintain the processes that you're going to put in place to really set yourself up for success. So what are some potential solutions? Really inventorying your current processes. Assess your compliance with the standards, schedule a health equity training session, attend educational webinars so that you can get insight into what are the standards really saying, what does this mean for your organization, and how do we implement this? How do you work with what you have in place and get to the next step? Next slide. With the transition from multicultural healthcare distinction to health equity, one of the standards that was introduced was HE1. And HE1 really sets the foundation for the culture of the organization, including leadership, the C-suite, board level positions. And some really look at this as, oh, I check the box. I have this. I have a DEI council. I have an EEO statement. I have what's needed. We can march forward. This is easy peasy. And that's not the case. And so what we're recommending in our potential solutions is really to engage with senior leadership. And sometimes what comes from is they're not really understanding what that means to the plan, right? So the decision to pursue accreditation might come from above, but not necessarily realizing the impact to leadership themselves, right? And so really want to encourage you to identify senior champions that can advocate on your behalf and help you to obtain that senior level buy-in, if you will. And then there must be some of those difficult conversations, acknowledging bias and having the ability to create an environment that you can talk about some sensitive topics without retaliation about each person's opinions and experiences. Sorry, just making sure there was an issue with audio. I saw a lot of chat over here, so my apologies. So, and then the other piece that I'm going to mention actually on the next slide is really putting some money behind this, right? So what I've seen as successful is making these as corporate goals. And that comes from the board as well, putting some teeth behind it again, right? To make sure that this is a goal and a desire for the entire organization, not just staff, not just leadership, but up at the board level as well. The other thing that we've seen is that sometimes, much like we see in health plan accreditation, is that health equity accreditation is designated or the responsibility of one particular department, quality, or perhaps a health equity department. But this accreditation really does take the commitment of the entire organization. And so again, mentioning those corporate goals that are tied to equity, not just for the staff, not just for the board, but even what does that mean about the membership that you are supporting, the individuals the community that you are serving. So sometimes what better way to demonstrate that is by having those corporate goals and establishing that corporate-wide or organization-wide commitment. Next slide. Over the years, we've encountered many organizations who can describe for me verbally and tell me their process, and they've been doing it for years, but there's nothing written down and nothing to point to. This happens more often than not, I think, in health equity, because I'll use the example of even translation, written translation. That might be a process that's in place already that is second nature to you. The marketing team they do their thing and they get the documents out in the translated in whatever language it is that's necessary. But there's no written documented process. Well, in health equity accreditation, these things have to be written down as part of your accreditation. So how do we overcome this? How do we get to the point where we have documentation? Seems like a simple solution. Schedule a working meeting. I know that this is challenging. It's not rocket science, right? Put pen to paper, sit down, invite the right people to the meeting and invite key stakeholders. I think as a consultant and even on the plan side, when I was bringing forth the first multicultural distinction, I literally sat in a room with the people that were responsible for that particular task, pulled up a piece of paper and start typing away, right? So get it pen to paper. It may not be pretty, but at least get something written down. And I will tell you, even on this side, as a consultant, that's often what we're doing, working with clients, because everybody, doesn't have the bandwidth. And sometimes it just means getting people in the room to write down what's the process. And what you see on the left-hand side is also partial documented processes. And I mention this because sometimes you have pieces of the puzzle. We can recognize that there are other areas that might have a portion of the requirement written down, but they don't have it fleshed out, or it doesn't necessarily meet the requirements. And so we can build upon what is already present, but it takes inventorying that, right? So to go back to what we talked about even earlier, inventorying what is currently in place and seeing how we can get it to where it needs to be for health equity accreditation. The last one I want to mention is the regurgitation of the standards. And this one is really important. It's the same thing that you'd see on the plan side. And I like to mention here also, when we look at the standards, one of the things that we talk about even as surveyors is looking at those key terms that NCQA uses. Words like specify, the term how, describe the process. And that's because we want to see what is the actual workflow. What does this look like? So just restating the standard does not explain to the surveyor or to anyone reading that what is your organization doing and what is the process. Think of what needs to happen if someone else were to pick up the baton and to implement whatever it is that is outlined in that documented process. The other challenge that we see is focusing on that element stem. And this kind of goes along with the documented process challenge that we just talked about. And it's really important that you consider the element stem, the scope of review, and the explanation together. These things work in tandem. Can you go back to the previous slide? Sorry, thank you. So again, paying attention to those key words and recognizing that the scope of review is really what we're looking at is what are the types of documents that as a surveyor, as a consultant, we should be looking for or at. And the explanation is helping us to understand, and you as the organization to understand, what are the details required in that documented process. There's a lot of content to consider, an explanation and a great level of detail really in the health equity standards. So I encourage you, if you have not reviewed these standards, really pay attention to what is being required, those fine sentences. Every one of those is applicable and is something that we as surveyors and as consultants have to consider when we're reviewing documents. Next slide. One of the other challenges that I've noticed is really unaware of all the data sources, and not necessarily data sources instead, really all the data is from. So this goes again back to what we were mentioning, I mentioned earlier, is that inventorying of not just your process, but also your data. Where are all the paths of data coming into your organization as well as going out of your organization? How are data shared across platforms, across departments? This is going to be really important, especially as NCQA has introduced the delegation requirements and thinking about what potentially could be considered delegation as well. So also we want to think about what are data points that you can leverage that are within your organization. Customer service, case management, are there platforms or processes that you can build upon if you don't have the data? What can you glean from that? And also thinking about how the data are stored, how things are overwritten. So you can see the theme here of allowing adequate time, making sure that you have these working meetings, inviting key people and those stakeholders to the conversation of, where all the data coming from and how do we get it in the door? How do we get it out to actually report on it as well? Really important. Next slide. As that one's queuing up, along with data and analyses, we want to talk a little bit about goals, stating goals in a quantifiable manner. NCQA is really specific in the standards. You'll see if you've had an opportunity to look at it, is making sure that the goals that are in that the goals within your program description, as well as within your analyses, are specific, time-bound, and so this requires you to do some homework. This requires you to pull the data. So hopefully you guys are seeing the theme of time and the importance of time and making sure that you allow for it, because you can't, if you don't know where all the data are, if you don't have the data, how are you going to establish some of these priorities? So broad statements like reducing disparities, obtain accreditation, increase education are really not going to hit the mark here. There needs to be those terms need to be followed by a numeric value and preferably time bound. And establish a reference point. So making sure that it is a quantitative and qualitative analysis. We will always encourage you to do that, even though the standard doesn't call that out, but this is what is more meaningful to you as an organization. And especially when it comes to health equity work, you want this to be meaningful, not just for you as an organization, but ultimately to impact the members and the individuals that you're serving. So let's use an example. Our next slide is going to queue up a possible goal that I know I've encountered a few times. I've seen obtain accreditation as an example of a goal in a program description. That doesn't reduce disparities, right? That's great for you as an organization, but what does that mean for your membership? We've seen data collection as a goal. And here's one that if I use what I just said earlier about being time bound or even having quantified, would this work? What is the specific race ethnicity category quantified? Is improving data collection for a specific category a goal? So if I increase that or improve it by 20% of that unknown category? And the answer is no. The goals should be are really for the actual provision of class or reduction of healthcare inequities that reflect the community that you serve, the needs that you've identified, those opportunities for improvement. And so again, this requires you as an organization to have taken the time to look at your data and to really evaluate what's important to your community, what's important to your membership, what are the potential disparities that you're seeing in the population. So you can't just back into this. And I think that sometimes we see that happening. I recognize that some organizations, again, having those state federal or regulatory requirements or even corporate requirements to achieve accreditation by a certain time point can really work against you. So it's really important that you take the time to look at the data and find those meaningful goals that you can obtain and work towards. Next slide. Again, with that transition from multicultural distinction to health equity, we saw the introduction of the requirement for organizations to collect sexual orientation data and gender identity data, also referred to as SOGI data. And eventually, the intention is to report on it. So when we began talking to plans pursuing accreditation or who were being required to do this as by regulatory requirements, this was a common challenge that we discussed. How do we introduce this? This is something that's uncomfortable. It is not currently in practice, and that especially for Medicaid organizations, this was a special challenge because they have most of the data might come across on enrollment and they have no control over how that data are collected. And one of the things that we really did encourage folks to do is to advocate. If the state is requiring you as an organization to obtain accreditation, behooves them to make some of those adjustments on their end as well on the enrollment form. And what I'm really glad to share, and hopefully, and maybe there's some of you that are in states that are making these adjustments. California actually is planning to add SOGI data collection to its enrollment form, and we're beginning to see this in other states as well. At least 4 or 5 other states that are expanding the options beyond male and female, or allowing those write-in options. And the intention is here, whether you agree or disagree with this, is really to create an environment where members and individuals feel comfortable sharing that information and making that healthcare accessible to all. Really, that's the intention, right? Is to make healthcare accessible, but we can't do that without information. We need that information to understand some of the needs. And so this is really educating your staff how to ask these questions, how to thoughtfully ask questions, how to educate members on what this means when you're collecting the data. Why are we asking it? And that could be putting information out, not necessarily for just the intention of collecting it, but purely for creating that environment and setting the tone to be able for allowing individuals to begin to feel comfortable about sharing this information. So again, that takes time, right? Next slide. Another challenge that we've seen, and I mentioned this, the implementation plan, right? So with this, the introduction of the SOGI data collection requirements, NCQA has allowed some time for organizations to implement these requirements. And so what we've often seen is that organizations say, well, there's an implementation plan. I can just create that. I don't need to do anything else. I don't need a documented process. Nothing else is required. And that is not the case. So remember earlier when we said it's really important that you read the scope of review along with the explanation and the data sources. Well, in the scope of review for these, for HE2D, D, and E, it specifies that a documented process is required for all survey types. There's no exception there. The implementation plan only applies to reports or materials and for that portion of the requirement. So again, really important that we're paying attention to those ands, those ors, reading the scope of review in its entirety. I can't tell you the number of times that myself and some of my colleagues have been in conversations with our clients, and they are, yep, we got an implementation plan, we're good to go. And we say, where's the documented process? And it's deer in headlights, because not realizing that, wait, we still need to have a process. Now you might ask, well, how do I have a process in place if I don't know how I'm going to collect it? But the intention is just what we talked about in the slide before, is beginning to create that environment of what will this look like? How are you as an organization preparing your staff, preparing your membership, preparing individuals? What will this look like? So take some time and steps to do that. Next slide. One of the other areas that we want to talk about too is the introduction of delegation requirements. So NCQA in the one of the iterations of the Health Equity Accreditation requirements introduced delegation. And this is a unique challenge because this has introduced some layers. So when we talked about inventorying your data sources, all the data that's coming in the door, this has been a sticky subject, I will say, for myself and some of my colleagues and working with our clients, because many of you that work on the plan side, there are some entities that are considered a vendor relationship on the health plan side, but because of the data collection requirements in health equity and the way that this is worded, NCQA sees these as delegation on health equity side. So this has required us to have some additional conversations about really evaluating how are all the data coming in the door and who is doing that function. So really important questions to ask within your organization, not just inventorying all those data sources, but who are the individuals collecting the data? How does that come in the door? How does it come to you? How do you ingest that information as well? So this goes back to, like I said, identifying those key stakeholders, having conversations across the organization. So you can see this is really an organization-wide commitment. It is not one unit. really requires the entire organization to work together to figure out how is all this coming in the door. And I think your HEDIS team is a really great area to tap into, because these are areas that are probably getting some of the data already, and some quality team, they're all already getting some of that information, but being able to, that could be a starting point, right, of how do you engage them and to just account for all of that information, but really teasing out what is delegation and what is not. Next slide. The other area that I wanted to mention before we transition into some best practices and suggestions is really establishing a sustainable accreditation. As you might imagine, if you, and I can certainly understand this might be challenging for some organizations if they are working towards trying to get their accreditation within a 6-month time frame. And there might be some processes and things that are put in place that truly are not going to be able to move you to that next level into that renewal accreditation. Once you've achieved that initial accreditation, right, we're jumping right into renewal with that 24-month look back period. If you as an organization have had this mass push to get the accreditation and perhaps did not take the time to inventory everything, to have strong documented processes, take the time to look at the data and establish some good, identifying disparities, but also analyses or areas of focus that you as an organization want to pursue, then you're really setting yourself up into that renewal cycle. This holds true even on if we think about health plan accreditation, you'll often hear, we don't want to drop the ball in that in-between cycle. Quality it's a year-round thing. Accreditation is ongoing, and the same holds true for health equity, if not more, because a lot of these initiatives really need to be in motion so you can have that time to be able to evaluate, to assess, to reassess, and implement changes as moving forward. So how do we overcome this? Really monitor it twofold, a couple areas, and I know I didn't mention them all on here, but monitor those NCQA FAQs, those policy changes. Just like health plan accreditation, the standards are going to change year over year. There's going to be new information, nuances, clarifications, things that we've learned, things that NCQA has learned on what is happening. So really important for you to pay attention to those changes and account for them in your process. And that goes back to the earlier, very early on, we were saying, line it up against what the standard is requiring and what your policy outlines. And so if you think about there's 3 years is a long time, right? And so if you've come through in the early parts of health equity and now are transitioning into a renewal survey, the standards have changed slightly. The expectations have also changed for you. The implementation plan goes away on a renewal survey. So what have you as an organization done? I will say also as a surveyor, I know personally, my expectations are a little higher if you've moved from that initial survey to a renewal survey. The expectation is that you've done this, you have identified some disparities, you've put some real things in motion. It's not a check the box, it's really walking the walk and putting meaningful interventions in place that have the ability to impact individuals, communities, membership, right? The other areas, of course, attend trainings and educational sessions. There's always ongoing trainings and sessions that are available. Attend health equity trainings that we offer as well. So I'll just put that plug in there. But really that making the time to invest in this because it is meaningful for your membership as well. Next slide. So I want to talk a little bit about some best practices. So if you've tuned me out, the last 2 slides, I'll ask you to tune back in on a couple areas. And so if you have not heard my theme of time, we'll start off with that one. We will always, most times we will recommend that minimum. I do say minimum because there are times it might take longer, really. And this goes back to inventorying, right? So allow adequate time to prepare. And this is really key to your success and really key for you to establish and maintain a culture of success. Really enforcing that organization-wide commitment, evaluating your current workforce and needs. What does this look like for your leadership? Where we've seen great success is where we've seen commitment from leadership on down. And this is very similar. This, for those of you on the health plan accreditation side or any other area of accreditation or certification, this should not seem unfamiliar to you. This is the same thing. When you hear that level of commitment of leadership, it comes across. It's not just lip service. You're walking the walk, and you're really allowing for those resources, the allocation of resources, and as I like to say, putting your money where your mouth is, right? And so, and the other area is really collaborating, communicating with internal departments. Across the departments, there's opportunities to really leverage what other areas are doing. Think about PHM, there's a lot of crossover, and as NCQA has continued to integrate the health equity standards on the health plan side, and PHM and NET, we can continue to see the need to have those conversations and not have health equity just be another check the box and accreditation that you achieve and maybe within a certain unit. This is really across the organization. In partnering with external resources, I do think that there's opportunities there to leverage existing technology to support your members, to support your organization. But as I said earlier, just be very mindful of what that looks like as NCQA has introduced these delegation requirements. So tease those nuances out. If you're one of our clients, we're happy to have that conversation with you, what that looks like or what are the potential challenges. And this shouldn't be a deterrent, right? We want to have our clients and our customers to be able to really engage and collaborate. That's part of this health equity journey, is that this is not a silo. It's not something that's happening just within your organization. And I think that comes through not just in the health equity standards, but more so on the health equity plus side, where there is that need to engage with other organizations, with other community-based organizations, because they've been doing this work for quite some time. So really critical to your success, not just doing this within your own walls, but engaging with other outside organizations as well. One of the things that often Susan and I will say is that these things can't be done in a vacuum. You really have to consider those various departments and the work that is going across all the departments. So just really make sure that you are considering that. One of the other bullets I wanted to mention is down at the bottom here about ensuring data are maintained and separate from data overrides. I know that's really specific. We just touched a little bit about data. But for those that, when we're talking about all the data systems and inventory, you also want to account for what's coming in the door and what is potentially overrides, and being able to establish kind of like your own space of data, of being able to access that information for the purpose of analyses, for identifying those disparities. There are a lot of systems in place that have those overrides. And let's take the example of if a member-facing unit is collecting information for the organization and housing it in a system, but then there's another data feed that overrides that, you've lost all that valuable information. The same holds true as if you're on enrollment forms that have race ethnicity data that have far more detail than if they were being rolled up into the OMB categories, right? Again, I know this is specific, but these are the things that are going to be important to you to be able to maintain some of that data so that you as an organization can look at what are truly the disparities, and being able to get to that granular level, far more detailed level than maybe those higher level categories. And so you're able to engage and identify opportunities for improvement and to implement interventions that are very specific to a population. I like to use myself as an example. I am of Indian descent. I get categorized as Asian in race ethnicity, but perhaps my cultural beliefs are going to be different than someone else of Asian descent. But if you have that information, then you know how to communicate with different individuals. That's the level of detail that is important. So sometimes it's taking a step beyond what's just in the standards and doing what is best for the individuals and the membership. So I encourage you to do that and dive a little bit deeper. Next slide. Okay, so really, if you weren't paying attention to me, this is my last one before I transition back to Susan. So key takeaways, if I've not said it enough, I will say it again. Make sure you take the time, make the journey meaningful to your members and community served. This is what Health Equity Accreditation is really about. This is not a check the box. This is not marching orders from your leadership. This is about serving the people that you are there in that institution to work for. And so make it meaningful. Engage your community leaders, engage with community-based organizations, obtain input, get their feedback, identify what's important to them as well. And as we said, read all those sub-bullet requirements, because as a surveyor, we're looking for every one of those. As a consultant, that's what I'm looking for. And again, leverage, build on existing programs. A lot of organizations, especially that are state funded, might have some performance improvement projects that could be leveraged. That is fine, but make it meaningful, right? I've mentioned that to organizations. I'm all for using what you have and building upon what you have, but make sure it makes sense to your membership. Make sure it makes sense based on the data that you have and what you're seeing as a disparity. And lastly, if you conclude that you're doing everything right, you're probably wrong and you haven't dug deep enough. So dig deep and keep looking at that data, and so that you can really identify again what's meaningful for your population. With that, I'm going to turn it back over to Susan for some special offers that you probably mentioned at the very beginning and upcoming events. Susan?
Yeah, thanks so much, Sonia. Great job. And, you know, when you get the standards, you look at them and say, so what? So what are we supposed to do? How are we supposed to do this? How can we avoid all these landmines that are inherent in accreditation? And so that was the spirit in which this was done. I don't know if you saw that there was a poll that you could take. If you look to the right of the question mark at the bottom of your screen, there's a bar graph icon. If you haven't taken that, please do that. Half of the people, when I last checked, had taken that, which showed that a lot of people were in the middle of their journey or in the last 12 months of their accreditation journey. And some had already gone through accreditation. So kudos to you folks. So there are a couple questions, and Tricia is going to give those to you, Sonia, for you to ask. And it's about SOGI data.
Yeah, so the first of those is more of a comment that when talking about the collection of SOGI data, we found that members really struggle with why we're asking for it. And I think we as an industry could do a much better job of explaining why it's so valuable. So I don't know if you have any hints or thoughts about how you explain the importance of collecting this data.
Yeah, I think it's a great question. I was anticipating SOGI data collection, so I'm not surprised to hear that question. I will say I absolutely agree. This is a struggle for all, and I think that really goes back to what I was saying of creating that culture of making people feel comfortable asking the question. And I think part of the challenge is that we expect it to be right away. And what I'm saying is take the time. Don't maybe putting the education out there first without the expectation of having receipt of that data. That takes time. And so creating that environment to me means just putting the information out there. Why are we doing this? Help to inform the membership. Don't just, and not just jump right into, we're asking you this information, now give it to us, right? So give it some time. Allow people to digest what this means to you as an organization, why you're doing it. And there's a lot of statistics out there. There's lots of data out there of what this means for members, right? So those in the LGBTQIA community, what this means for them as they engage with practitioners, as they engage with providers. Use that information. This is meaningful because this is important to our membership and we want to create an environment where everyone is able to access care. I hope
Right.
that helps.
The second question also related to, well, broader, if we receive race, language, or SOGI data from provider offices to supplement our gaps in enrollment files, is that considered delegation?
Great. I knew that one was coming too. So NCQA has said, and I will confirm this just one more time for as Susan mentioned at the outset, that sometimes things change, right? But as of my most recent inquiries of them, it really depends on how you're getting it. If you are getting electronic, if you have access to electronic records, that is acceptable. NCQA is not putting a kibosh on that and calling it delegation. What we have seen is if someone else is collecting it on your behalf, like you have hired another entity to perform like the HRA data collection, and they are actually engaging with individuals, asking those questions. That's the kind of thing. I know that might sound similar to maybe what a provider is asking questions, but I think they're allowing that nuance because clearly there's that's a little, we don't want to introduce delegation in that regard. So NCQA is not taking the stance on delegation to my knowledge, but I can absolutely confirm if you Trisha, if you have that individual's information, if they've put their name, I'm happy to confirm that and send that out too.
So they submitted that as an anonymous attendee, but
Okay.
we can, if you want to drop your name in the chat, we can make sure we follow up with you individually. That was it for questions in the chat or in the Q&A right now. Are there any others people want to pop in? Maybe Susan, you want to go ahead with the other items and we see if there's any other questions.
Yeah, absolutely. We can always come back if you want to take a minute to put something in the Q&A that just came to you. So there is a limited time offer. If you're not a client in the next 2 weeks, you can ask for a free 20-minute consultation with one of the team leads. Just notify us at the email there, and then you can have that free consultation. You will be getting a copy of the slides and a link to the recording after this meeting is completed. You'll also get a questionnaire of satisfaction, just really brief. And I know people get so sick of satisfaction questions and get that, they call it fatigue, survey fatigue, but it really does help us in this quality improvement process, which we do use for that feedback loop to provide the best quality of information and meeting the needs of those who are that we serve. Whether you're a client or not a client, we're always glad to provide this information. You can go to the next slide. And we have some upcoming events. If you're a client and going to the Health Innovation Summit, please, you should have received multiple invitations from us on the client-only dinner on November 1st. It's the night before the last half day. And we do have a restaurant there that we have retained that is 10 minutes from the venue. So please let us know. We'd be glad to have you and meet you, talk to you up close and personal, since we only do remote work at this time and it's nice to meet people in person. We'll also have a client webinar in December where we share the policy changes and surveyor update insights. We just had a surveyor update training yesterday. It was all about the information integrity, and that was shared actually when we talked about the proposed standards back in I believe it was May, June timeframe. And so that's the same thing that we shared at that point. And if you weren't part of that and you're a client, please let us know about that and we can talk to you about it. We have a complimentary general webinar annually that we're planning to discuss the proposed standards after NCQA publishes them. And we want to give you a consultant perspective on the impact on your organization in the months until they're formally punished. Yeah, is that maybe a Freudian slip? I don't know. anyway, that is something that we plan to do because most of the proposed standards are initially or eventually adopted or tweaked a little bit. So we want you to have a head start on what's going on and give you our perspective on what that means to your organization. Next slide. Just to let you know, we have templates and tools. Our clients get these at a reduced price, but these cover the scope of the standards. And so if you are one of our clients, you can get it reduced. If you are not a client, we will have this available in the near future on our website that you can order those. And if you are not subscribed to our monthly newsletters, we will announce it at that point. So you can go on our website at managedhealthcareresources.com and contact me, or just send the note to the email about VA at managedhealthcareresources.com and get put on our list. But you should be, if you registered for this, you should be put on distribution. You can always opt out. I think that's keep going. That we do have a staffing assessment. You can go to the next slide for training. This is a newer product that we have to help you do an internal evaluation with a consultant of what's going on, and to give that data-driven evaluation to executive leadership to help justify the FTEs in your organization. This is probably the biggest concern and barrier that we have from all of our clients. And so they don't have enough FTEs and bodies to go around, and everybody is getting stressed, and then people are leaving and taking all that great history and knowledge with them. So please, if you're interested in that, just give us a notification and we'll be glad to discuss that with you. You can go to the next slide. These are just listing a lot of our training presentations that we have, and it covers the scope of the standards, and we have them for all different products that NCQA publishes. We do have another one that's more recent that our clients have liked, which is Train the Trainer and how to audit files like a surveyor, because a lot of you have internal audit teams, and a lot of times you don't know, are we really applying these correctly? And so we go through and give you all of the ways that we go about it, the questions we ask, and how do we get to the end result and score that. So we have found that's been greatly appreciated by our clients. Next slide is our ending. Has any other questions shown up, Tricia?
Yes. Yeah, Susan, there's actually a question that relates to one of our prior webinars where we were talking about kind of an automatic or use of AI and auto authorizations, system generated approvals only, and they're wondering if there was an update on that.
I would have to ask Sonia. I was off for a couple months, so I don't know if there was an update while I was off. Sonia, are you?
I'm gonna, can you hear me okay?
Yeah.
Yep.
I'm gonna double check. I believe one of our consultants did get a response. If it looks like we have a name, perhaps we could follow up. I'll confirm.
Yep.
Oh, yes.
Okay, I'll confirm with our consultant, internal consultants, and get back to you.
Okay, great. Yep, great question. That's that was
Nope.
one that was, yeah, causing some consternation. So
I do have a quick one. NCQA stated they were going to consider it, but no timeline for when they would actually get to it. So I believe it's not acceptable at the moment, but they will consider it.
okay,
So yeah.
great. Well, thank you so much for your time today. We know that your time is valuable, and we're glad that you invested in learning about health equity and the challenges that everyone meets as they're on their journey, because the themes are the same, folks. We see the same things, and as you heard Sonia reference me, and what our perspective is, because we are both extremely passionate about health equity and health equity accreditation. And so we've done a couple seminars nationally on that. So it's just really something that we enjoy talking about. So thank you so much. And we're right on target for our time frame. So take care, folks. Have a great weekend.